So this is a little bit about the history of fluoroscopy. Thomas Edison invented fluoroscopy in 1896. The original composition was made of a phosphor screen with a lead backing. The design of this was not optimal because it resulted in low light images, and the images were viewed directly by the radiologist, and when you were viewing the images, they were viewed in complete darkness. The main problem is that it caused decreased spatial resolution and it increased patient exposure.
Fluoroscopy units are now composed of image-intensified systems and flat panel detector systems, which uses different materials and decreases patient exposure. In an image-intensified system, the input phosphor converts X-rays to light. The photocathode absorbs that light and converts it to electrons. The output phosphor converts light back to electrons, but there are more electrons than when we started with, which causes the image to be brighter than previously achievable. There is a video camera, which converts light to video signal. The video signal travels through an ADC, or an analog to digital converter, which converts video signals to digital signals. This allows images to be stored and processed on the computer monitor. Modern fluoroscopy is typically used in pulse mode rather than the previous continuous mode, where the beam is pulsed and decreases exposure to the patient and technologist.
So this is a stationary fluoro unit, which is commonly seen in the departments, while this is a mobile unit, which is used in surgery. They both have above table configurations where the image intensifier is above the patient while the X-ray tube is below. So when using the C-arm and you angle the tube, you need to make sure you're standing opposite of where the tube is angled to decrease radiation to the tech. And when the beam is vertical, you need to stand as far away as possible with a minimum of 6 feet in order to decrease dose.
These are some of the buttons that you commonly see on a C-arm machine. So this is the save button. It's one of the most important buttons. It allows the image to be recorded on the display monitor so that you can come back and view it at a different time. These are the orientation buttons. It flips the image around so that you can better visualize the structure. These are the collimation buttons. It reduces patient exposure because it reduces the size or the amount of tissue that's being irradiated. Another important button is the pulse button. It allows the generator to produce a pulsed X-ray beam, which this decreases patient exposure and it increases image sharpness.
Okay, so this button changes the image from the left workstation to the right workstation and vice versa. If the doctor wants you to save one image and put it on the other screen so you can look at it at a later time. These buttons change the orientation of the film on the display monitor. So these mirror while this one rotates it side to side. These control your exposure factors. You can increase the KVP or the mass, which decrease or increase the patient exposure. The alarm reset is for when you have 5 minutes of cumulative fluoro time, and an alarm goes off to let you know that you're exposing the patient for 5 minutes, and then this resets the alarm. And low dose changes the fluoro to where the contrast is a little bit less, but the big dose to the patient is also less.
This is a basic configuration of a C-arm. So some of the things that you can do, you can drive the C-arm in and out, so towards the operating table and away from the operating table. You can move it up and down in height. This is your wig-wag, which moves it from left to right. You can also move it proximal and distal across the part that you're imaging. And then these are going to move it from your AP to your lateral so that you can get the lateral view of the structure you're imaging.
When going into surgery, sterile attire is required as to not contaminate the patient or the equipment. There is a specific order to put on the PPE for the OR after changing into the specific scrubs. First, you put on the little booties to cover your shoes as to not get any blood or fluid on them. Next, you put on the hat to cover your hair. Then you put on your mask. Then you put on the sterile gown, and then gloves are last because you need your hands to put on the rest of it. Next, we will discuss the rules for maintaining the sterile field.
First rule for maintaining the sterile field is not to turn your back to the sterile field because you won't know if you got too close or if your back brushed against it. That's contaminating the patient and causing unwanted germ spread, which could cause the surgery to start completely over and having to do a whole complete sterilization.
The next rule is when you're using a C-arm, you must not contaminate the sterile field. So when you're moving from AP to lateral, you want to be careful that you don't touch the sterile drapes because that can contaminate it and you might have to restart the surgery and it's just dangerous for the patient.
When using the C-arm, you have to make sure that you don't bump anything non-sterile when the sterile drip is on top of it because you have to get a whole new bag and that can hold up the whole surgery because they need to see exactly where they're putting all of their hardware and their needle placement, so that can cause a lot of issues within the surgery.
When you're wearing your sterile scrubs and your sterile gowns, you want to make sure that you understand that everything below the waist is not sterile and only from your hands up to your elbows are sterile when you have your gloves on.
Only sterile items can be used in the sterile field in order to maintain the cleanliness and to not cause unwanted germ spread.
The next thing you want to be aware of is equipment that might be hanging from the C-arm. So when you're moving the C-arm around the operating room, you want to be careful that lead aprons and items that are hanging from the C-arm don't contaminate the sterile field.
Only sterile people can handle or touch sterile items, so you have to be in the complete sterile scrubs with the sterile gloves on in order to be able to touch all of this equipment and to make sure that there isn't any germ spread to the patient.
The last thing to understand is that when you're moving the C-arm around the room, you want to be careful that you're not hitting the sterile drapes with the C-arm and that you're also not hitting the sterile tray with the C-arm. This is me demonstrating the use of a lead apron. Lead aprons should always be available when you're using fluoroscopy in the OR. You should always wear this lead apron to protect yourself from extra radiation dose because, after all, you're going to be in this career for a while and you should take the necessary precautions to protect yourself.